No. Can you hear me? Okay. Yeah. Thank you for coming. Tonight we have Dr. Brent Carmack, who's sitting right over here. His lovely wife and two of his children are over here. So, and Stephanie's a nurse practitioner, geriatrics. So, if you have any, elderly parents, none of us are elderly, just so you know. So you know who to talk to. So, anyway, thanks to everyone for coming. We had a really great presentation last week, and next week we have dietary. So we're not doing a pre-test today, so you're off the hook. We did one last time. So we're going to do some different things. Anyway, I'm going to turn it over to Joanne Matthias, and she's going to prayer or Bible verse or something.
I'll do a prayer. Please pray with me. Father, thank you for every seat that has been filled here today, for each mind and heart that fills the presence of this room. We thank you. Only you truly know what we are setting out to accomplish today. We have an idea, a vision, hints, and daily instructions. We have talents, abilities, and time to work. However, only you can see in perfect detail the end of every beginning, every project, every reason, every life. Nothing is ever in vain, for even mistakes and missteps are used for good. Bless this gathering today, all those present, as well as the lives of those we will encounter afterwards. Ready us to make every moment count. In Jesus' name we pray. Amen. I am pleased today to introduce Dr. Carmack. He is an ophthalmologist with offices in St. Petersburg. He graduated from the University of South Florida. Go Bulls. He completed his residency at the University of South Florida Eye Institute. He is board certified and specializes in diseases of the eye and eye surgery. So please help me in welcoming Dr. Carmack.
Let's see if this thing's on. Can you hear me? Good. Okay. So it's pretty informal. Anyone has any questions, they can interrupt me. I was recently at a lecture, and I love ophthalmology, but it was the most boring lecture I've ever been to in my life. So we're going to try not to make this terribly boring, hopefully. Okay, so why don't we just go to the next slide right off the bat. So I'm just going to talk about some common eye problems. You might not think dry eye is a big deal, but literally everyone has it who looks at a computer all day, tries to read at night, drives with air conditioning in their eye, sits under a ceiling fan. People come in all day long and be like, oh, why are my eyes burning? Why am I tearing? It's kind of counterintuitive. People with dry eye actually have tearing. Because a good example is if you go in front of a fan and try to not blink, your eyes are going to tear. So it's like a reactive tearing. Anyways, just a quick thing on that. If you have dry eye, use artificial tears. They're over the counter. And so that's that. That's my most boring thing of the day. So I'm going to talk about cataracts, glaucoma, macular degeneration, and probably something about floaters, because I saw some questions about that. And then I'll answer questions at the end. Next slide, please. So that's just an example of dry eye. It's really not, if you're not an ophthalmologist, you're not even going to know what you're looking at probably, but we put some dye on the eye, that greenish substance, and anywhere it's dry, it actually fluoresces, and so it lights up, and that's just someone when their entire eye is dry. So a lot of these people have intermittent blurriness, so they'll like blink, their eye will kind of be coated with tears, and then they'll open it, and a few minutes later they can't see again. A good analogy is if you're in your car, and your windshield wipers aren't on and it's sprinkling raindrops, you can't see. You hit the wipers and now it's clear again. So it's the same thing with the eye, so it's a very common problem. Okay, next slide, please. Oh, those are causes. Basically, postmenopausal women, people with hypothyroidism, people with autoimmune diseases and certain medications, even taking Benadryl can dry out your eye. Next slide, please. No, actually, it's really common in like middle-aged people that look at computers all day long because you don't blink. When you're concentrating, your blink frequency diminishes because you don't want to have to refixate on whatever you're scanning when you're reading. So it's very common. I mean, unbelievably common. So, yeah. Okay. Cataracts. This is my favorite subject. People have the perception in many cases that cataracts is just a film over the eye. I actually wish it were that simple because it would make my life easier, but not as fun. Cataracts are actually your natural lens that you're born with becoming opaque. So it becomes cloudy, so you can't really see as well. You lose your contrast sensitivity. You need more light to read. At night, when light is transmitted through an opaque lens and you're trying to drive and your pupil gets a little bigger, you see glare and what we call starbursts, and people just become totally dysfunctional driving at night. Many of my patients, I give them my cell phone number and say, if you're coming on the road and you're not having surgery, call me before you drive so I can get off the road. So, I'm serious. So it's not a film, and it can't be removed with just laser, can't be treated with vitamins, diet, nothing. The only way to get rid of it is surgery. Hence, I have job security, because everyone gets cataracts. If you think you're not going to get them, it's just not true. If you live long enough, you get cataracts. Everyone. So diabetes is a very common cause. You talked about COPD last week. A lot of those patients are on oral prednisone. Steroids are a big cause, not the lift weight steroids, but the anti-inflammatory steroids. Trauma is also a big deal, but mostly the most common cause is age. Next, please. Okay, so this is an example of what a cataract should, what your normal eye would see like a sunflower as, and what a person with real cataracts actually sees. Believe it or not, it can be that dramatically blurry, and it can happen usually very slowly. I have patients that are definitely not legal to drive, and they say, I see fine. Well, the reason why is because if every single day of your life, after you hit like 60, it just very slowly gets worse, you kind of adapt to it and almost assume that's your new normal. So it's a classic example. If like 10 years ago, I gained a pound of fat every day for 10 years. And I still think I know I don't look too fat, but when I look in the mirror, I'm like, I'm just as skinny as ever. And then I'm like, wait a minute, because I didn't even notice, because I gained weight every single month, every single year. So I'm about 10 pounds over what I was 10 years ago. So next slide, please. Okay, this is what cataracts look like. So probably in adults, you don't see, in humans, you might not see cataracts get this bad because most people are already at the ophthalmologist. But a lot of people have seen these when they have a dog, because dogs don't get cataract surgery as often. Actually, dog surgery pays a lot more than human surgery, just so you know. It's like, say, here's how much it is, and insurance says, well, I'll give you 1/10 of that. When you go to the hospital, it says, oh, your bill is $100,000, but don't worry, you owe $10 and your insurance paid us $20. I mean, it's crazy. So anyways, if you look at a dog that has an opaque pupil, that's a cataract, and I see them all the time at the dog park. It's really important to notice something. So the cataract on the far right is actually got like a greenish, brownish color. It's called brunescence, and I'm really excited to show you another slide in a couple minutes that explains what that is. The one on the upper left is just an average cataract, and they would get surgery. But the one on the bottom it's very white, and it's called a hypermature cataract. You don't want to wait till it gets that bad. But those people, they literally can't see the big E on the chart. They can barely see your hand moving in front of your face. And you'd think I wouldn't see those very often, but it's surprising because people are kind of scared of surgery, so they just won't come in. It's usually men, and their wives force them to come in, and then I give them some Valium, and they're fine. But they want the surgery the next day because they're going to sit around and worry about it, Next slide, please. That's me. And on the right side, this is just kind of a blow-up of how cataract surgery is still done by some doctors, but it's kind of the older version. That's supposed to represent a cataract behind the pupil. The reason you don't see the pupil is because the eye is so dilated. So that little probe in there is an ultrasound, and it vibrates so quickly, it actually liquefies the lens, and then we simply vacuum it out. Sounds terrible, but I like to say rinse it out with saline. It sounds so much better. Next slide, please. Okay, this is a great slide. So on the upper left is the anatomy of the lens. The outside is called the capsule. So with the cataract surgery, you have to carefully make a circular opening in the front of that capsule. Then you have to get down inside, and you have to take out the nucleus, the very center area. It looks like a football, and all the tissue around it called the cortex. But the catch is that on the back side of that capsule, because it goes all around, you cannot break that. If you break that, it's a major complication. Now, it can be fixed, but it's no fun. So do people know what's on the right side there? Okay. So I'm going to tell you right now, I will hire you, and you can work at my office at a pretty high salary if you can do this tonight. If you can take a peanut M&M, okay, and you make a round circular opening about 5 millimeters, it might have to be a little bigger depending on the size of the peanut, and you make an opening in that shell, and you get the nut out and all of the chocolate, but you can't break any other part of the shell, then you can do cataract surgery tomorrow. I'm not kidding. That's how it is. So just, if you can leave only an empty shell, and not break it except the small circular opening in the front, you actually could be a cataract surgeon. I'm serious. Okay, next slide, please. So this is an actual cataract, not an M&M. And this is how we used to do when I very first started training, when I was, yeah, right? This is what we did. We took out an entire cataract in one piece, and then we had to suture the cornea. So now there's no such thing as sutures. If you're throwing sutures, either the person doing it's very old or you had a problem. So I probably haven't thrown a stitch in a decade because the way I do it is it's sutureless. Next slide, please. Okay, so this is also a modern day, but again, this is still an older technique. So remember that ultrasonic probe I showed you on the first, one of the early slides? So that cross there isn't because we're in church. That is a method where we sculpt out the lens and then we break it apart into quadrants and then we basically aspirate it or vacuum it out of the eye. And so that is your traditional cataract surgery. So the right instrument is going through a wound that's 2.4 millimeters, and the left hand is going through one that's 0.8 millimeters. So that's pretty small. People think, like, how could you possibly do that? Well, if we have a microscope, it's literally that big in front of our eyes, so it's not a huge deal. I wanted to pass around a couple things while we're at it. You can pass these around. If you drop it, it's no big deal. You just have to recite the entire New Testament. So this is an actual intraocular lens. Don't worry, this is not, it's the lens that we put in the eye after cataract surgery. That's the actual size, that's the one I use. It has a black mark on it, not because I don't want people to see, just to make sure no one tries to put that in an eye later because it's not implantable now. But you can pass, and again, if you drop it, don't worry about it. And if you can't see it, then you better come see me. All right, next slide, please. Okay. We're back to the boring part of the lecture, but I thought someone might ask me if there's any engineers in here. So the newer way to do cataract surgery is by bladeless laser cataract. So it's called a femtosecond laser. So basically, it's unbelievably accurate. It's literally accurate down to a micron, which is 10 to the minus 6 meters, thousandth of a millimeter. And so basically, we create something called plasma, and we break apart the lens, and we cut the cornea, we make that opening in the M&M, that circular opening. And actually, if you can do it with a laser, you still can work at my office. If you want to buy $1 million laser and do that tonight on your M&M, you can still work with me. Okay, next slide, please. So this is just because I like to show, remember that giant lens I showed where you just stick a scalpel and then I pull out a giant lens and suture it? It's become so advanced now that I actually do this by computer. I have a mouse and I have foot pedals and different things. And so the yellow area there is the actual lens on its side. So I can decide how deep to cut the lens. And that on the left side, that's actually me looking straight down on the eye. So the bluish circular color is the actually iris, the colored part of the eye. The reason that hole in the middle looks so big is because the pupil's dilated. I'm sure you know, but the pupil, it's not actually anything. It's just a hole. There's nothing really there. It's not a structure. It's just an opening. So anyways, I do things by computer now, and it's pretty cool. The average scan takes me about 1 minute and 30 seconds, and the average to do the cuts through the cornea, that's 2 cuts, open up the front of the lens and cut the lens into pieces, and also make any astigmatism corrections. On average, that part of the treatment's about 38 seconds. And that's actually long because I use higher energy than most people, and I put the spots closer together so that it's more likely to break apart the lens. So like between 36 and 40 seconds is like your surgery time for that. And those steps usually on a standard case without the laser take me, I don't know, 5 or 6 minutes. So it's that big of a difference with the laser. Okay, next slide, please. So this is actually a laser, and again, I know we're in church, so I wanted to show another cross. So earlier I showed you how you sculpt that cross out manually. Well, the laser actually makes the cross cuts for you. So it's already broken into pieces. And that circular area is the opening in the lens, so we can get to those quadrants. And we basically just engage them and basically suck them out of there. And again, you wonder how can those pieces get through a 2.4 millimeter opening. It's because, again, that ultrasound probe, as it brings it out, liquefies it. And if you see on the bottom right, about maybe 5:30 o'clock, there's a little area there. That's actually the opening for my right hand. and that's what the lens implant will go through. And then the left side, that's the opening for my left-hand instrument. So, people saw those lenses? Okay, so the lens has to go through that bottom right opening, and the opening is only 2.4 millimeters, but the lens is much larger. So it's rolled into a little scroll, pushed through that wound, and then we open it up once it's inside. Next slide, please. So on the left-hand side, this is a lens coming out of an injector. It's not a needle. It's an injector, though, with a blunt tip. And then it just comes out and opens up on its own because it's the type of material where it will just spontaneously open. The thing that we passed around earlier, a lot of people ask me, well, what were those wings on the side of it? So the part that you see through is the center, the round part. But the sides are actually to hold it into place. And there's two things that hold it into place. One is mechanical, as those wings or those arms basically expand out. But the other is there's a chemical attraction between the lens itself and the bag or the capsule that we put it inside of. So it's really stable once it's in there. Don't worry, that was another lens being injected. Okay, so on the top, this is the thing that if anyone in here has had cataract surgery or you know someone who has, many times they will tell you I had to go back and get zapped with a laser. Okay, so cataracts cannot come back. Once it's out, it's out. But there can be a proliferation of cells which opacify the vision again because that part of the back of that M&M shell that I said you can't break, it gets cloudy. So interestingly, you can break it now because the eye's sealed up. The reason you can't break it during surgery is because the eye essentially has an open hole in it, and so the pressure can fluctuate. So if you break the capsule during surgery, two things happen. The lens that you're trying to take out falls back into the gel, which is really bad. Or the gel can come forward into the front of the eye, which is also really bad. So once the eye's stable, you can break open that membrane with a laser. It's painless. It takes approximately 1 minute. I did like 4 of them today. Maybe, 2 or 3 at least, I think, today. And we make a window in it. So we make that little window on the right, and we make a cruciate incision. Ophthalmology is really, really like going to church and surgery because we make an actual cross. And when we make that cross, the tissue's under tension, and it pulls itself into a diamond shape like that. So, all right, so next slide, please. I had a really cool slide that we're missing. Yeah. Yeah. Yes. Mm-hmm. I mean, it's always a risk. I mean, between the U.S. and Canada, the risk of that's, probably 1 in 1,000 or something. Well, I just did cataract surgery on a cataract surgeon who came to me, and he had a disease where he had weak zonules. It's a known disease that causes glaucoma, but also causes the lens to jiggle out of place during surgery. So that's a lot of fun. He wanted to come to me. Luckily, we got through it. He didn't have a problem. He didn't need a capsular tension ring or any different lens. But the other lens that you put in, it goes in a different location. It can't sit in that bag because the bag is broken. So it sits up right behind the iris in a little space there called the sulcus. And those lenses have a firm, like when it springs out, on that lens, probably no one tried to do it because they couldn't, it was too small. But the lenses I use have, those little wings are compressible really easy, like you can just push them in. But on the other ones that you had to get, it actually springs out and it really can't move because it's not held in with that chemical attraction and it's in the wrong spot essentially. So, I mean, that happens. It's usually patients still get very good vision. It's just, it takes longer to heal sometimes. Oh, yeah. Yeah, sure. Some people are born with cataracts. Oh, yeah. So I'm supposed to talk about congenital cataracts. So congenital means you're born with it, basically. And so congenital cataracts are actually pretty common. I did surgery on like a 14-year-old last summer, and her sister and her mom also had cataracts. I did her mom's surgery. She waited till she was like 40 because it wasn't that bad. But her sister got surgery by somebody else. And you're born with cataracts. It can be genetic, or it can be some sort of insult in utero. So people who get a bunch of, like, let's say your mom gets measles, or let's say she gets it's called the torch infections. There's a bunch of different infections you can get. But that can definitely induce cataracts as well. So we see those, and the question always is, when do you take them out? Well, the visual pathway completely develops by age 10. If you can't see by 10, you could take out a cataract, you won't see well because your brain doesn't know what to do with the image because the brain processing center basically doesn't know what to make of this new data that it's getting. So in a kid, we want to do it fairly soon. You see kids walking around with patches all the time. The point of that is to try to, actually you patch, kind of sounds weird, you think you'd patch your bad eye, you patch the good eye. Because if you don't, the brain will just never use the other eye, it'll just completely ignore it. So yeah, so you take them out. The big controversy is when do you put a lens implant in? I say do it right away because you don't want kids wearing this thick of glasses or trying to get a contact lens in their eye. So the problem with that is the eye matures, really it's full size by about 2. So if you do it before age 2, I'd rather wait because if you do it before age 2, then you really can't put a lens. And then you bought them a second surgery. Now you got to go back later. So I like to do things in one surgery if possible. Any other questions right now? No? Okay. I'm surprised I'm missing this slide. Can you go down and back up on a couple slides? I just want to see if something's there. Did we miss a slide? I had a really cool picture. Do you see a painting anywhere on that? Was there a painting? Go back up and see. I guess it's not there. That's terrible. It was such a good picture. Okay, so here's what I had. I had a painting of Claude Monet, and there's 2 pictures. It's a bunch of lily pads, okay? The first picture is unbelievably good. It's bright blue and just, it's emblematic of his works. It's just unbelievable colors. And there's a second one below it that is really muted. It's brown, it's green, it just doesn't have that same type of appearance. And so you might wonder why that is. Well, I showed you a cataract early on that was like greenish color, brownish green, we call it brunescent. So he thought he was painting the same thing because his perception was that, oh yeah, look at these colors. But he couldn't see the colors like we do, or whoever doesn't have cataracts here. So he kept painting, and his pictures kept getting different and different and different. There was nothing different about his technique. A good art curator at a museum can take an impressionistic painter and say, this is a young work, this is middle age, this is older, because they can actually see that shift in colors. So we don't like to let patients get to that stage, but I have many people who come in, they can't see color too well. So, but anyways, that's what happened. I had a really great picture. So sad it isn't here now. Okay. And by the way, please interrupt me if there's anything you want to know. Go back up, please, to glaucoma. Oh yeah. What is glaucoma? Too high of pressure for your eyeball. I read a question. Yeah. Sure, yeah. Yeah, you're probably allergic to the drop too. Yeah, it'll still kill the, if you have, yeah. It depends if all the drops bothered you. A lot of times people are allergic to some of those drops you use to treat the eye. It was probably what's called blepharoconjunctivitis we see. Oh, yeah, he just wants to make sure you're not allergic to the drops, but I don't know, I wouldn't do that, but that's just me. I would just give you the drops. I'm serious, if it starts to have a reaction, you just modify them. Yeah, I would find out which drops work for you. But, oh, Facebook. Oh my goodness, there's the picture. I can't believe it. So the upper right is before he developed cataracts, and the lower right is after he developed cataracts. Yeah, he went to Paris to find out, because people started telling him, like, something's wrong with you. So he went to Paris in, like, 1912, and they said, hey, you've got cataracts. But this is before modern-day cataract surgery. It was no joke. Like, even if you go back to, like, the 1950s, 60s, you're going to be sandbagged in a hospital, not moving your head for weeks, and sutures everywhere. It's unbelievably different now. Great. Thank you so much. I'm so happy. Next, please. So glaucoma is too high a pressure, basically. So we'll go and look at a couple things. So it's interesting. High pressure, it's multifactorial, but most of the time it's just a genetic predisposition. So the pressure is high because for some reason your eye's producing either too much fluid or it's not draining enough fluid. Now a lot of people say, well, I don't tear or whatever. It has nothing to do with the outside of the eye. It has nothing to do with tearing. It's internally. There's a circulation of fluid throughout the eye constantly. And so the pressure builds up. So we either have to use drops to lower the pressure. We have to do surgery. There are many techniques. But if I diagnose glaucoma, the chances of someone going blind are nearly zero. The people who lose vision are people who don't get diagnosed, or they're not compliant with the treatment. They refuse surgery. They won't take drops, something of that nature. So, So if you were an ophthalmologist, you'd know that an optic nerve should have a tiny little hole in the middle, like a white spot, and everything else should be pink and red and healthy nerve tissue. So that white area is actually, there's no tissue there. It basically died. So when I look in someone's eye, I can tell if they have glaucoma a lot of times right away. Next, please. So what happens with glaucoma is you lose, I think this is my old presentation I emailed, but you lose vision and you get shadows in your vision. So this particular individual has really lost all their vision in the upper half of their vision, and it's basically because of glaucoma. Next, please. So that's a normal retina. We're going to move on. So just so you know what a normal retina looks like, and that's an abnormal retina. That's macular degeneration. You don't want that. That type there is dry, and what it means is that when it says degeneration, the tissue that you actually see with is degenerating. So the support tissue for the cells that sense light called photoreceptors just basically degenerates, disintegrates, however you want to look at it, and you lose your central vision. So with glaucoma, you get almost like a tunnel vision. With macular degeneration, you lose the center, which is terrible. I'd rather have side vision loss because I can function, but when you have macular degeneration, if it's bad enough, you look at someone's face, it's actually missing. You try to read letters in a book, it's frustrating because you can see the edges of the page, but you can't read what's on the page. And I had some pictures that demonstrated that, but I guess this is my old version of the thing. So that is wet macular degeneration. There's a hemorrhage there. This is much more serious than dry. Dry can be really bad, but it takes years, if not decades, to cause vision loss. But the wet can cause vision loss really immediately. I could see someone one day, they're fine, the next day they can't see. So that's no good. The treatment for that is shots in the eye, by the way. I'm sure you've heard of people. That's bleeding, yeah. Yeah. You had a shot yesterday? Who did it? Yeah, I know, Scott. Did you go to 56th Street or Siemens? Yeah, you went to the Tampa. Yeah, well, that's what I meant, up by Fletcher and 56. Yeah, I know that group. I refer to them. Yeah. So now it's question and answer time. Yeah, I've got some questions, but I saw someone raise their hand. Yeah. So, we think that antioxidants play a role in decreasing the progression of macular degeneration. A study came out in October of 2001 with 3,600 patients that basically saw how much macular degeneration was slowed down by a particular subset of vitamins. They're called the AREDS vitamins, which stands for Age-Related Eye Disease Study. And now there's an AREDS 2 because the original one had something called beta-carotene, which is related to vitamin A, and they found out that may increase the risk of lung cancer, so they quickly modified the formula. These studies sometimes amplify the benefit of the study because I read it and oh my goodness, it's like a 21% risk reduction, but they manipulated the stats, so the difference was 7%, but somehow they came up, the real improvement, it's 7%, but they said, the relative risk reduction is 21%. So they kind of fudged the numbers. So if you ask me how much better that is than Centrum Silver, probably not much better. The difference is it's actually truly studied. So like if you just take it as a preventive measure, you don't need to pay twice the price for the eye vitamins. But if you actually have macular degeneration, we actually suggest that you do actually take the subset that's been proven by the National Eye Institute of Health to decrease your risk. I mean, even if it's 1%, it's probably worth it to prevent blindness, so, yeah. Oh yeah, for sure. Yeah, 100%, absolutely. The difference between now and when I first started training is unbelievable. When I first started training, we had to laser out the wet part and basically blind them to say, hey, we're going to create a blind spot, but it'll prevent you from having a bigger blind spot later. But we're going to immediately make you see worse so that 5 years from now you see better than you would have. So it's a terrible thing. So now we have injectables that basically kill off those abnormal blood vessels, because wet disease means there's abnormal blood vessels bleeding. So yeah, and I actually did early studies on that a long time ago. You can look up a publication if you search my name, because I said I don't want to kill off retina with a laser. There's got to be a different way. And they came up with a cold laser. And then I said the cold laser doesn't work through layers of blood. Because at one point I was looking into retina, not just cataracts. But I fell in love with cataracts. I saw like 10 hands go up, but let's go. Go ahead, blue shirt. Yeah. Yeah. Well, really, well, I would say really bad is exceptionally rare. I know I've done over 4,000 cataracts. Now, I wouldn't say I've maybe had one really bad outcome, but they still saw. They just weren't, perfect. So as far as really bad, it's really rare. But as far as like a complication where you need a second procedure, it's about 1 in 1,000. There's a thing called endophthalmitis, which is an infection in the eye. If you get that and it's not treated really quickly, then the person's definitely going to lose their vision potentially. So, light blue shirt. Yeah. Yeah, wear sunglasses. He wants to know about a pterygium, which is a growth on the eye. That was Dr. Kulik, probably. Yeah. Yeah, lid speculum. Yeah, never had that before. Yeah, Jeff Quitko. Was he nice to you? Yeah. I've never had that happen, but yeah. It has to be really rare, because the way that we manage the eyelid, it's so precise with basically opening it to just the right amount that we need. But yeah, so I'm sorry that happened to you. Yeah, I take those off. Well, it varies from doctor to doctor. For me, I do a taper of drops over like a 1 month period where you slowly take less drops. But usually a good month would be safe because you want to prevent inflammation. I actually recently changed to injecting the medicine right under the surface of the eye, because a lot of people aren't compliant. They can't. If you're like 90 with Parkinson's, you're not going to be getting a drop in your eye. So I can inject medicine that just slowly absorbs, so that I can even do dropless if I have to. Sure you can, but you shouldn't need to if you got a good lens implant. Yeah. Yes, in the back. Yeah, so this brings up a whole topic that Denise wanted me to speak about. The most common eye emergency is a retinal detachment. It's bad, but it can be fixed. And it's not an emergency, I guess. It's more like an urgency. So if you're just sitting around and a shade's coming across your vision and you can't see, that's probably pretty bad. That means your retina's probably detaching, possibly. The issue is you really need to talk to an ophthalmologist, because other things masquerade as that. You can have an ophthalmic migraine. You can lose part of your vision for a period of time and not even get a headache. So it's called an ophthalmic migraine, where basically the blood flow in your visual cortex gets reduced because of spasm of the vessels, and the next thing you know, you're missing spots in your vision. So a lot of people will come in panicked about that. And the other thing that is also, actually I think the number one emergency would be a phenomena where you get a clot or a plaque from your carotid artery or your heart that travels into the eye, and then it gets caught and it blocks your vision. It can go away on its own sometimes as it passes through, because the pulse will keep beating that piece of plaque or clot or whatever it is, and then the vision may clear up. But the issue is that the next stop after the eye is the brain. So if you're having a temporary black spot in the vision that lasts a minute, it comes and goes, and it's not in both eyes, it's one eye, that's usually a TIA, and you got to get that addressed, because the next stop's the brain, and you're super high risk for a stroke. I just had someone like that 2 days ago. So, but going back to the retinal detachment. So the retina is like a membrane in the eye. It's kind of like the film in a camera for people who still use film, not digital cameras. And it just peels loose, and that is very common. And what precipitates it is something called a floater. I would bet a lot of people in here have little floaters. If you look up at a bright light or the sky, you'll see little amoeboid-looking things floating around. Those are affectionately referred to as floaters. They're actually just an irregularity within the gel of your eye. And when they move around, since they're attached to the retina and they peel loose, they can pull part of the retina with it. The most common, like if it's being pulled, you'll see a flash or a spark. So if you're seeing like sparks or lightning bolts, that's when you probably need to go see the doctor for a dilated eye exam. But this is why ophthalmology is such a specialized field. You can have the same symptom and it can represent 3 or 4 or 5 different things. If someone comes in with a red eye and you look in a textbook from Wills Eye Hospital, they have 50 diagnoses of what a red eye could be. So, it's not just, oh, can you call in an antibiotic? I probably have conjunctivitis. Well, you could actually be going blind right now. So like when you have a red eye, you have to know what it is. Going back to one other emergency is a corneal ulcer. If people wear contacts and they sleep in them, that can be bad. You can get an infection that perforates your cornea, and that's also not very good. You want me to get that list? Oh, go ahead. Mm-hmm. Yeah, the optic nerve goes out the back of the eye to the brain. You can think of the nerve like a fiber optic cable, basically. It carries all that data from the eyeball, and then it sends it back to the brain, and the brain interprets what to do with it. Yeah, so only in people who have successfully done that with contact lenses, or they've had LASIK with monovision. Monovision is where you make one eye your dominant eye for distance, and you make your non-dominant eye for near. People love it or they hate it. So a lot of doctors in town actually will say, hey, I'm making her monovision. They've never even had monovision. Then they come out of surgery like, oh, that's great at this eye, and I can't see anything in this eye. And then they have to convince them like, well, you can see near in this eye, but not this eye. And it's really bad. I get 3 or 4 second opinions a month from that. Someone just did it and it didn't really clarify with the patient. A lot of these places, you don't even see the doctor. You just have someone say, hey, we got the measurements, see you in the OR. So you got to be really careful about that. Expectations are important. So I always talk to my patients to find out what they want. There's different types of lenses. There's multifocal. There's lenses that let you just see distance or near. The multifocals let you see distance, near, and everything in between. I was going to actually pass around. Do I still have time? Okay. Oh, we do? Okay, cool. You'll probably have to tackle me off the stage because I'll keep talking. So I'm going to pass around a blown-up version of, this actually could go in like a whale eye or something, I don't know. This is monofocal, meaning that it just has one focus. And this is what a multifocal lens looks like. It's rings. Like a lot of people ask me, like, well, what, do I have to look down to read and look up to see distance like a progressive pair of eyeglasses or like a bifocal? The answer is no. This technology was taken from telescopes that explore space. So telescopes in space have to have different focal points, but yet if you have moving parts in it, you're probably, if it breaks down, going to probably not be able to send someone up to fix it all the time. So they came up with a static lens that allows you to see different distances, and that's what this is. So there's circumferential rings, and each ring is a different focal point. So the clear ones for distance and the ring ones, so just so you can see the difference. And yeah, they have fingerprints on them, but I clean them all the time. Yeah, you probably see just the lens. If you got that, the second type of lens, you got a multifocal for sure? How much did you pay extra for it? Did you pay a lot of extra for it? Yeah, okay. Yeah. This gentleman in the blue had a question, right? No, woman in the red. Cosmetic, that's it. Like someone wants to take a brown eye and make it blue. I don't know why you would have a zero prescription on a contact lens. Oh, well, first of all, I don't even know. A zero prescription contact lens is called a bandage contact lens that we use for people who have like a problem with the eye. So I don't know why you would wear a zero contact lens. Now, you might not wear a contact lens if your eye is naturally distant or near and wear a contact in only one eye, but I'm not aware of any zero contact lens. I've never prescribed one. It would only be for changing your eye color or bandaging the eye if you had like a problem. If you have your script in your purse, I'd love to see it. Oh, wait a minute. It might be a multifocal zero contact lens that gives you distance. Yeah, that's what it is then. It's a multifocal contact. So that means you should be perfect at distance or whatever focal point they wanted, and then it has reading power on top of that. And that little thing circulating, that's what you have basically, but in a contact lens. Question? Are you sure she's old enough? You look pretty young. You have a daughter that old? Oh, congenital cataracts? Okay, yeah. Was that here in town? Was it Dr. Hess's group? Yeah, so it was either Hess or Roland or, Josh, whatever his name is, yeah. Okay, yeah, they do a good job. It was worth it. 100%, yeah, it was worth it. Okay, got to decide. I'm going to flip a coin. Which you haven't been called on, go ahead. Yeah, you can, as long as you do it within an early amount of time. You don't want to do it a year or two later because it can be scarred into position. You can have complications. But yes, I probably on my own patients, I've only had to do that once, but I've done quite a few of those from other doctors who maybe didn't get it right on. It's a complicated reason, but there's some sophisticated equipment that I have that I can more accurately predict what lens implant to put in. But basically, that is possible. But what's really easier is if you had just a mild, we call it a refractive surprise. So we were expecting one outcome and you came out either a little nearsighted or farsighted. So the easier way to deal with it is just get LASIK surgery over top of that because it's a surface procedure. It doesn't have really much risk, but going inside of the eye has more risks associated with it. So we don't like to do lens exchanges unless we have to. Yeah. Yeah, so it's only wet that we do shots for. Yeah. And so, there's different protocols and there's always something new coming out. But, it depends on what you have. If it's for macular degeneration, we do it for diabetic swelling as well. But yeah, it's like every 8 weeks, depending on which one you use. Oh, sometimes there's a protocol where we say you're only going to get so many shots, and then if it's not going to go away, that's it. But most of the time, it can be chronic. He knows from Dr. Potler. Potler does a lot of research on that. There's new ones coming out where they last longer, and there's even going to be like an implant you put in there at some point where you don't even have to keep getting shots. That is going to come out. Yeah. Nope. There is a phenomena where you can get inflammation in the eye because of the lens being positioned in not exactly the right spot and not the right size, but that's a mechanical issue. As far as the lenses, they're what we call biologically inert, meaning they don't stimulate an inflammatory response. The way that lens implants were really discovered was that fighter pilots in some of the early wars, their canopy would get shot, and pieces of the canopy would go in their eye and penetrate it. And then they were like, oh my God, do we have to take those out? Am I allowed to say, oh my God, oh my gosh, sorry, I'm in church. They say, do we have to take those out? And they said no, because they're not causing a problem. And so that's when they first fashioned the original lens implants, were from something like plexiglass. It's called PMMA, which stands for polymethyl methacrylate, if there's anyone out who cares. But, reposition it. Yeah. Lady in the back, please. So she's asking what uveitis is. That's basically the phenomena that I was describing where it's in the wrong spot. It's actually called UGG syndrome, not because the surgeon goes ugh. It stands for uveitis, glaucoma, hyphema. Hyphema is bleeding in the eye, glaucoma is too high a pressure, and uveitis is inflammation. So because of that mechanical phenomena, it causes uveitis, which is simply inflammation in the eye. Not on the surface like conjunctivitis. Uvea is the tissue like the pupil and the layer right in front of the retina, and that gets inflamed. So all it is inflammation, and it's usually treated by topical steroid drops. But the most common cause of uveitis is actually autoimmune disease. Yeah. So there's a really commonly associated condition called ankylosing spondylitis, and it's where people get like tightened up here and they can't bend their back. Actually, a famous person, but I will guarantee no one in here will know this, but there's a bassist, like a bass guitar player for a band from the 80s called Motley Crue. Anyone heard of Motley Crue? Yeah. So he actually has that, and so he has to he can't really stand up. So, right. Yeah, it's inside the eye, and it can be diagnosed real easily because you can see white blood cells circulating in the fluid. It's your immune system. Yeah. It can also, sometimes, even though it's infectious, we can kind of say, oh, we have white blood cells in there. Did it kind of cause a uveitic phenomena? But an infection's an infection. So uveitis is separate. It's your immune system reacting to something. Yeah. Oh, boy. Let's go right to left. That'll be the best way. My right. Yep. Yeah, so juvenile rheumatoid arthritis is highly associated with uveitis in the eye. It can cause a lot of problems. And they usually, though, now we're treating them with like immunosuppressants, like these, you hear about biologicals. And so usually, if you control the systemic flare-up, then the ocular side effects are pretty low. So if the systemic condition is controlled, then hopefully the eye inflammation isn't independent of the systemic issue. But yes, that's very common. Okay, we were going left. Yeah, LASIK, yeah. I've never even seen anyone lose vision from it. My wife just had it within the last year. Yeah. Yeah, and by the guy who trained me, he's done 60,000 LASIK procedures. If you ask him how many people have lost sight, I would guess he would say 0. I mean, there could be a suboptimal outcome, but losing sight, I don't even know how that would happen. I mean, an infection, but you'd recognize it and treat it. So you'd have to really, even so, yeah. Maybe RK if it was older than that, where we made incisions instead of a laser. But yeah, that would be extremely unusual. It's funny because one of my friends reviews lawsuits for that. And so he was reviewing a lawsuit, and he asked me to read the chart. I'm like, I don't know what's wrong here. And so this guy was suing a doctor, and I'm looking, I'm like, well, what's his vision? He's like, well, with glasses, it's 20/20. I'm like, oh man, he has to wear glasses still? I guess maybe he should at least be reimbursed for the procedure. So I said, well, what's his uncorrected vision after LASIK? He's like, oh, he never had LASIK. He sued the doctor because the consent wasn't good enough, and he said he had like traumatic nightmares because he was scared of getting LASIK now because he told them all that could happen, but then he left some stuff out. So he was suing the doctor. And you think that's funny, but that's the type of stuff you get. It costs money to defend that. So that's why malpractice is high, because there's a guy in Las Vegas that's called his patient fat. I mean, that's not the nicest thing to do, but maybe you need to wake them up and tell them to go on a diet. So it's not like you shouldn't get sued for that necessarily. You might want to leave the doctor's office and find someone else, but there's all sorts of crazy stuff like that. So, in the back, please. Yeah, sure. Yeah. I had a slide that showed what floaters look like, but basically, the gel inside of your eye, with age, tends to liquefy and shrink a little bit. So the shell of the eye has a really finite volume. It really doesn't change shape, but internally those contents can shrink and liquefy. So what happens is basically there's an irregularity in the optical clarity. Hey, look at that. So when people look out, they may see a floater like that. Good old Google. Yeah, so it moves when you move your eye. And that's why they're called floaters, because they float a little bit. And so one analogy that I don't know how good it is, but I used an M&M earlier for an analogy, so now I'm going to use Jell-O. If you had a bowl of gelatin in a glass bowl that was clear gelatin, like unflavored, you could see through it. And if you just went and stuck a fork in it and pulled it back out, all of a sudden you'd see spots in it. You didn't put anything else in there. There's nothing, no foreign object. There's nothing in there. But now there's spots. So that's kind of what happens to the gel of your eye. It becomes irregular, and there's clumping of something called collagen in there. And so when light passes through that, you basically perceive little shadows. So yeah, this is great. Yes?
I have a question in the back. I have
You're not allowed to- you're
a
not allowed to
phrase
ask.
on my boat. If you have $6 eyes, go ahead and wear $6 sunglasses. I wear $300 sunglasses. Am I doing better for my eyes
You're
than the
doing better
$6?
for the optical shop, I know that. No, you're not. The only
Really?
thing no. The only thing you're doing better is that you're seeing better, because, like, especially if you're on the water, a polarized lens, you can see fish underwater. Without a polarized lens, you really can't. And they have all these expensive sunglasses have coatings on them to reduce reflections and maybe enhance color and things like that. But if a glass is sold by like a reputable company, not something like at a flea market or in China or something, they have to be block UVA and UVB. So they're just as protective of the eye. And by the way, my lens implants block UV light. Yeah. So the answer is there isn't as big a correlation as people think between like UV light and cataracts and UV light and eye disease, because people are like, oh, well, in Florida, all these people have cataracts. There's a lot of sun there. Well, yeah, but there's also a lot of old people here, so that's kind of why. So that's why. But yeah, so I mean, I think it's worth getting for your vision, but as far as protecting your eyes, there really isn't a huge difference as long as they're UV blocking. Yeah, but you look cooler in the more expensive ones too. I mean, they're called blue blocker lenses. So, yeah, I mean, they kind of can help if like they have the new like car lights that are so bright. They can definitely cut down on some of the glare if you have cataracts. But like for a person who's younger that doesn't really have eye problems, I don't think they make a big difference.
Why don't we ask a few of these questions, and
Okay.
these are ones that people have.
Yes. Okay. Okay. Are you the brother of Brad Pitt? Obviously, I'm not an identical twin to him. I must be a fraternal twin. How do I know that I need cataract surgery? The easiest way is you can't see. I mean, seriously, I see people with cataracts all day long, and they're like, oh, my optometrist sent me here to a specialist because I have cataracts. What do I do? I'm like, well, you're 20/20, see me in 10 years. I mean, seriously, everyone who gets, if someone's 50, they have cataracts. It doesn't mean that they're visually significant cataracts. There are a few cases where you have to take a cataract out for the health of the eye, if its shape is causing glaucoma and other issues. But typically, cataract surgery should be done when it's visually significant. There are a lot of, I call them cataract cowboys, that if you show up and you're 65, you're getting cataract surgery whether you need it or not. But I am not that way. Okay, so, I mean, I wasn't trying to be facetious. I mean, that's legitimately the way to judge it. So if your doctor, and again, subjectively, you might not think it's that bad because you're used to it, but if you go objectively get measured and you look at the chart and your vision isn't 20/20 and the reason is a cataract, then you probably should consider getting it removed. The question is, what is the threshold? Well, it really depends on who you are. And that doesn't mean we're discriminatory about who gets cataract surgery. It means that you decide based on your level of function. So if I saw someone who was almost 20/20 and they're 100 years old in a nursing home, I'm not going to do cataract surgery. But if I had a guy who was actually a perfect 20/20, he said, I got to get cataract surgery. I'm like, I don't think I want to do it. It's not that bad. He's like, listen, doc, I really can't see. I'm like, well, you're 20/20. He's like, trust me, I used to see better. I'm like, okay, well, what do you do? He's like, I'm an airline pilot. I'm like, okay, let's hold on. Maybe we should do something, And so I ended up doing his cataract surgery. And here's the funny thing about it. I want to explain what 20/20 means. It's just basically a standard of vision. So if you're 20/40, that means you see half of what normal is. So if I, assuming I'm 20/20, see something, let's say 100 feet away, in your 20/40, you can only see that same thing at 50 feet away. The opposite holds true. If your vision's better than 20/20, let's say it's 20/10, you see twice as far away. So I did the guy's surgery, and he's 20/10. And so for him, when he was 20/20, that's half of what normal is. So at 20/10, he could see something when he's landing a plane 5,000 feet away that he said when he had the cataract, he could only see it 2,500 feet away. It was that big of a difference. And that's probably why he's a pilot. People go into fields that they're, have aptitude for. So he obviously had really good vision. So, was that the question? I don't even remember. Oh, yeah. Yeah, so it's based on your level of symptoms. So if someone has poor acuity, they have poor color, poor contrast, like Claude Monet, he can't paint, he should get cataract surgery. And also not seeing at night's a big one. If you can't drive at night. I have people all the time like, yeah, you probably shouldn't be on the road at night. And they're like, oh, I don't drive at night. And if I do, I know where I'm going. So I'm like, okay. What can you do about floaters? Okay, you should probably do nothing about them. If they're bad enough to justify surgery, we have to go in with basically a cutter that cuts the gel and sucks it out. And that's fine, but you don't want to get it unless you have to. But it's not something, has risks, and it's a lot to go through. So Dr. Potler's group, who you mentioned earlier, I just sent someone who is actually a professional golfer on the LPGA to one of his partners because they said that it was exactly when they looked down to hit the tee, the black spot was exactly on the ball. They tried everything. They moved their eye and it would float around and then it would settle down. It'd go right on the ball. And they said, I can't do it. So they got a vitrectomy is what it's called, and they're fine now. You'll see this medical news journal. It'll say like Pinellas Medical News. It is not medical news. It's an advertisement. So, and I'm not trying to badmouth anyone, but let's not use that journal. Let's just say somewhere you see someone who treats floaters with laser. Yeah, you probably don't want to do it. It's not covered by insurance. That's your first clue that it probably isn't really the standard of care. But basically, some people are trying to take a laser and they're trying to break up floaters in the eye, and then they're trying to make a big floater into little ones. The problem with that is you're going to propagate more floaters because you're liquefying the gel even more. There's even studies that show that increases the risk of retinal tears. Now, they're working on some different types of lasers that may be okay in the future, but right now, that's not the standard. If you go to a doctor and he says, hey, I'm like the only doctor in the nation doing this, then you probably don't want to do it because it's not the standard of care, So yeah, that's what you can do about floaters is do nothing. Get used to them. And your brain usually suppresses them after a while. Okay, someone here has been getting a film over their eyes, and it takes a while to clear. What is it? Well, that's a good question. Most likely, if it's intermittent, it's dry eye syndrome. If it takes a while to clear, if you use over-the-counter artificial tears, you'll know if it works, then that's what it is. If it doesn't, then you better see the eye doctor, if you know any good ones anywhere. I had a spike in my eye pressure. Any thoughts? Yes, I have a lot of thoughts about that. My first thought is, where was it taken and who did it? Because there's a lot of artificially false positives because a lot of people don't like things being poked in their eye. So people will squeeze their eye and hold their breath, and all of that can increase the pressure. And sometimes if someone goes to the mall or something, they use this this air puff test. And it's coming, and people are like this. That actually, if you squeeze the eye, it's like squeezing a water balloon. The pressure will go up. You can't pop it, but the pressure will go up. And so a lot of times I'll see someone say, hey, relax, we're going to do it with the most accurate method, and they'll have a normal pressure. So there's a lot of false alarms, but it should be taken very seriously. And the problem with having a spike in the eye pressure, it depends how high it is, the pressure fluctuates up and down. So I could see someone with a normal pressure, but who knows? They could go home and it could be way higher than normal. So we ask them to get like a journal of pressure over so many visits to kind of see what the trend is. So if you have high pressure and it spiked, you need a glaucoma workup, whoever that was. There's HIPAA now, so don't raise your hand. I might get sued. Let's see what else there is. Am I accepting new patients? Yes. 7/8/9/2020. Can you take cataracts off too early? No, not really. I mean, you can't take them off too early. I mean, since there's a small risk, you might not want to do it too early. If you see perfect, there's no reason to. The primary goal of cataract surgery is to safely remove a cloudy lens. The secondary goal is to basically get you out of glasses or fix your prescription. So a lot of people want to go, oh, well, I'm going to not have to wear glasses. I'm going to get cataract surgery. Well, that's fine. I mean, that's what I do, but I make sure they have an actual cataract before I justify going inside of the eye. Because again, that's what LASIK should be for. If someone doesn't have a cataract and they can't see. But if you have a cataract, yeah, we can fix the vision. So you can't do it too early, though. So it's real simple. The eye has a certain length and a certain curvature, and so mathematically we can calculate the optical power of the eye. The catch is that you can't just shine a light and analyze it and then it will tell you the optical power. I mean, it can. I can put you in front of a machine, push a button, and it will tell me, oh, well, your prescription's a -3. The problem with that is that when we do cataract surgery, we take the lens out. So the lens is a big part of the focusing. So when the lens comes out, the focal power of the eye is completely changed. So we use theoretical formulas to calculate the strength of the lens, and that's based on the length of the eye and the curve. But there's a new advance, which I do. Most doctors don't do it because it actually takes a couple minutes extra during the surgery, but I'd rather take a few minutes extra and get a better result. There's a new procedure called aberrometry, where once the cataract is out, in live time, we get live analytics where it projects an image into my eye and tells me your prescription in live time. So I may have planned to do one lens implant, and then I realize, oh boy, that's not the right one, and we have an assortment of lenses on consignment, so I have my nurse just go grab the right strength. So I actually did a doctor's eye on Monday, and his pre-op measurement showed that he had no significant astigmatism. When I did the surgery, he had a lot of astigmatism. And so the reason why is because the backside of the cornea can't be measured it can't really be measured with the machinery we have, but it's part of the optical power. So you base it on the front side of the cornea shape, but if it's not perfectly symmetrical, then you can have astigmatism. So even with all my years of experience, when I see a disparity, I was like, oh boy, I hope it's right. And it was. He saw very well the first day. But anyway, so if your cataract surgeon has that machine, it's just an extra step of making sure you get the right strength lens. Yeah, you could ask me tonight. Just ask me tonight. Who typed that? You know, I did this like I did this in like 15 minutes. I don't have dyslexia. 789-2020. I almost would have rather they called the wrong number than you make me look bad. I would have taken the. I don't need new patients anyways. Why are you red? I should be the one that's red. I need to see a good eye doctor. Yeah, fix it. I didn't look up there. Yeah, so there's no such thing as a macular migraine. There's an ophthalmic migraine, and there's a retinal migraine. The macula is just a part of the retina, so I don't mean to be too technical, but was it one eye or both eyes? Did you see a visual change, like a kaleidoscope or a flashing light, or was it one eye or both eyes? Was it one eye or both of the eyes? It was an ophthalmic migraine. Yeah. Yep. Yeah. Yeah, that's an ophthalmic migraine. So that's a lack of blood flow to the back of the brain, so you get a visual aberration. A lot of people come in. Yeah, usually it should go away in about 15 minutes, 20 minutes. If it lasts more than 45 minutes, it's typically indicative of a stroke. A lot of doctors just say, oh yeah, it's just an ophthalmic migraine. But I had someone recently that had it for like an hour. I'm like, that's a stroke. That's not an ophthalmic migraine. So they went to the ER, and sure enough, they had a stroke. Yeah. No, typically not. If you've had a history of migraines or a chronic history of the ophthalmic migraine, typically it's not of much concern. But the problem is you really can't diagnose it. There's no test for it. It's what we call a diagnosis of exclusion. So if someone has had a bunch of clots, pulmonary emboli, DVTs in their legs, and you start getting that, we're like, well, that could be a clot. But if someone's like super healthy, they don't smoke, whatever, like, yeah, it's probably, and especially if they've had migraines their whole life, then it's super unlikely it's anything worrisome. But yeah, as long as you don't have any other focal neurological deficits. So like if you don't have numbness, weakness, slurred speech, the other signs of TIA, it's probably just an isolated ophthalmic migraine. It'd be unlikely if you were throwing clots like a stroke or a TIA to go to the same spot every single time. It would probably go maybe the eye one time, maybe paralysis another time, weakness numbness another time. Last thing, risk of cataract surgery. infection and need for a second surgery, and of course that it might not come out with the perfect lens implant. That's really it.
All right. Thank you so much.
You're welcome. Thank you.
We have a little gift card in here for you. And
Oh, really?
he gets a
Oh, I didn't need that.
yes, thank
Great.
you so much.
Thank
You
you.
did an awesome job. I
Thank
really
you.
appreciate it.
Thank you.
And thanks, Stephanie, for helping us and helping him out here.
I'll never live that down.